I think when you're starting out and you're very new to clinicals, you're very hyper-focused on your task at hand, that you don't always notice what's going on with your vital signs. Your blood pressure and heart rate may be dropping really fast, so you have to be cognizant of all those things while you're giving these medications. And always have your emergency equipment ready just in case, any emergency drugs. If that makes you feel a lot better by having any, if it makes you feel better to have your stickineo or ephedrine nearby just to help you out during induction. And have that emergency equipment ready just in case you run into trouble with the airway and anything else that can happen.
Hello, future CRNA. Welcome to CRNA School Prep Academy podcast. I have a very special episode lined up for you today, and it is part of our guest host series where I am bringing current SRNAs on the show for you as a guest host on the CSBA podcast. And my thought process behind doing this is I wanted you to hear from current students, a variety of current students who are at different stages of their CRNA journey, and really allow you to kind of step into their world and hear them talk about what it's like to be a current student dealing with things like difficult preceptors or different anesthesia topics, clinical topics, maybe even things like time management, stress management, things like that. I think these episodes are going to be gold, and I hope you enjoy as much as I always do hearing from current students. I know for a fact that the reason why CRNA School Prep Academy is where it is today, and the reason why I have learned so much is from diving all in, listening to current students along with CRNAs share a wealth of information and really kind of taking all of that information and kind of compiling it into kind of the system that we have created today. And I know that you're doing the same thing by tuning into the show week after week, developing your own method, your own strategy, and your own system for success. So I hope you enjoy these guest episodes. Let's go ahead and get into today's show.
Hi everyone, I'm Pauline, SRNA Paul on Instagram and YouTube, and I am the guest speaker for this week's episode of the CRNA School Prep Academy podcast. This is my very first episode on this podcast, and today we're going to talk about patients that are harder to sedate than others and why. So a little bit of background about me. I am currently in my second year of CRNA school. I've been in clinical for a full year now. Our first 6 months has been general surgeries, and we jump straight into specialties the last half of this year. So I've done my OB, neuro, and pediatric rotations so far. I was a travel nurse prior to starting CRNA school, and I remember going to my different assignments, listening to the CRNA School Prep Academy podcast while I was applying to CRNA school, and it's just such an honor to be here today and talking to you guys about anesthesia. After being in clinical for quite some time, you'll notice that some patients are harder to sedate than others. I've found myself having to give more propofol or turn up my anesthetic gases in order for them to go to sleep. You would give the appropriate weight-based dosages of the medications and they would still be wide awake with their eyes open and staring at you. So to start things off, let's talk about the different types of patients that we see that are harder to sedate than others. The most common patients that we see that are harder to sedate are patients with red hair or redheads, patients who consume a lot of alcohol or recreational drugs, patients with high anxiety, and patients with tolerance to opioids and sedatives. Before we talk about the reasons why these patients are harder to sedate, let's talk about MAC. The minimum alveolar concentration, or MAC, is the concentration of anesthetic gas that suppresses movement in response to a surgical stimulus in 50% of people. Inhalation anesthetic requirements is usually quantified using MAC. There are factors that increase and decrease MAC. Factors that increase MAC are chronic alcohol consumption, emphasis on the chronic, increased central nervous system neurotransmitter activity, such as acute cocaine or amphetamine intoxication, hypernatremia or high sodium, infants 1 to 6 months old, hyperthermia, and red hair. Factors that decrease MAC are acute alcohol consumption. Acute alcohol consumption decreases MAC, while chronic alcohol consumption increases MAC. Sedative drugs, hyponatremia or low sodium, old age, and pregnancy. So all of these factors decrease MAC, meaning that they would need less anesthetic requirements. With these factors that increase MAC, it would mean that they would need more anesthetics on board. So MAC is a core concept in our anesthesia practice, and it's something that is tested on in CRNA school, on the sea, and on boards. So it's really important for you to know the different factors that affect it. A lot of you may have already heard that patients with red hair or redheads are harder to sedate compared to the non-red-haired patients. There are many studies done on this, and they show that redheads require way more IV anesthetic and anesthetic gases compared to non-redhead patients. The phenotype of nearly all red-haired individuals can be traced to a distinct mutation of the melanocortin-1 receptor gene, or MC1R. This is a key regulator in the intracellular signaling biosynthetic pathway governing pigment formation. This identifiable human phenotype can be traced to a distinct genotype that has a genetic influence on anesthetic sensitivity, just as redheads do. So I found it very interesting that the anesthetic sensitivity is affected by a genetic mutation in redheads. So in my experience so far, the most common patients that I see that are harder to sedate are those who consume a lot of alcohol and recreational drugs. Sometimes patients don't tell you exactly how much alcohol and recreational drugs they intake, and you only find out during induction, and it's taking them a long time to go to sleep, or you're having to give them a lot more medication and gases. I found that this is more common in patients that are older, men or women, or in younger patients from ages 18 to 40 years old who consume marijuana and vape on a daily basis. A heavy dose of alcohol also increases your gastric acidity and volume. It also impairs your laryngeal reflexes, making them prone to aspiration. Patients going through withdrawal can show symptoms of tremors, tachycardia, cardiac dysrhythmias, hypertension, and nausea and vomiting. These are all symptoms that can affect our anesthetic plan, so it's important for you to do your full assessment on these patients. And with cannabis, it has a high fat solubility, which leads to prolonged effect in the system. These patients can show symptoms of anxiety, tachycardia, and even seizures. Cannabis shows an increase in the sympathetic nervous system, causing tachycardia and cardiac dysrhythmias. It causes a decrease in the parasympathetic nervous system, leading to myocardial depression. So if you know that your patient has taken any cannabis or amphetamines or cocaine, you have to be careful of the medications that you give in your anesthetic plan. These medications that you have to be careful with are ketamine, atropine, or epinephrine, which can increase your heart rate even more. There are also patients who are on chronic opioid and seizure medications. These patients may present for surgery exhibiting opioid tolerance secondary to chronic opioid therapy for chronic pain. They may also have active opioid use disorder or a history of opioid use disorder treated with medication. These patients can be challenging to take care of in the perioperative period due to their tolerance, opioid-induced hyperalgesia, and higher post-op pain scores. And when you do your neuro rotation and when you start learning about remifentanil, you'll learn about hyperalgesia, which is a big side effect of remifentanil. So you really have to be mindful of those things, especially with these patients who are already in chronic pain. They may require up to 3 to 4 times higher dosages of opioids compared to the non-tolerant patients. So during the procedure, you may find it challenging to deal with their rising blood pressure and heart rates, and you have to constantly treat those vital signs. Giving a lot of opioids leads to a risk of complications such as excessive sedation, respiratory depression, and increase hospital stay length and costs. In pre-op, make sure you check for the medications that they take, any fentanyl patches, and their baseline levels for their pain. Take this time to talk to your patient about your plan for the management of their pain and expectations for the type of surgery they're going to have and the recovery for it. Different surgeries produce different types of pain, so it's good to be realistic for what they can expect post-op. If it's a short, quick procedure, you may not have to give any opioids. But if it's a long, more than 3-4 hour procedure, expect that you may have to give a little more longer acting opioid. So how do we manage the anesthetics for these patients who are harder to sedate or who have tolerance to pain medication and sedatives? Where I practice my anesthesia, we use a lot of multimodal analgesia. This can optimize pain control and reduce the amount of opioids that you give to your patients. Examples of medications that we use for multimodal analgesia are Precedex, ketamine, gabapentinoids, nonsteroidal anti-inflammatory agents, and Tylenol. In pre-op, they can get Tylenol, Celebrex, or gabapentin. It really depends on the provider. And during the procedure, you can also give other medications that can add to that full coverage of pain control. So if they haven't gotten anything in pre-op, you can do it yourself and give the extra multimodal analgesia. We can also use regional or neuraxial anesthesia for targeted isolation of painful or noxious stimuli. I think regional anesthesia is one of the best things that we are able to do as anesthesia providers, and being able to do epidurals and spinals for OB. For ortho cases, we can do so many different types of blocks for that. And it just gives us a lot of options as anesthesia providers to relieve that pain.
A daily dose of inspiration from a CRNA School Prep Academy student. I just got accepted to the U.S. Army Graduate Program in Anesthesia Nursing starting in 2023. Some facts about me. I've been a nurse for 8 years, the last 4.5 years in the ICU. The first 2 years of ICU was in a mixed ICU at a level 3 trauma center. They had general MICU, surgeries, head and neck, GI, open heart, working with CRRT, inner aortic balloon pumps, Impellas, and ECMO. I traveled as a MICU SICU with, of course, lots of step-down tele floating for 2 years at various level trauma centers, and then settled at a level 1 CT ICU for the last 6 months with heart and lung transplants, ECMO, LVADs, CRRT, Impella, and inner aortic balloon pumps. I did 2 medical mission trips last summer, one with IVHQ and one with One World Surgery. I highly suggest One World Surgery because I got to shadow 5 anesthesia providers between 3 ORs. One was even on the AANA board. I also attended 2 and 1 national AANA conferences. These were crucial in meeting with professors, and I was even preemptively invited to interview and had multiple invites to see their schools and shadow lectures and labs. Networking and fully immersing myself amongst SRNAs and CRNAs was amazing, and I even grew my own passion for the CRNA political community, and I just cannot wait to be an advocate. I also met Richard Wilson and Jenny Fennell, both incredibly welcoming and helpful in meeting with other professors as well. Thank you so much for everything. I know if you're listening to this right now that you know who you are, and it was so incredible meeting you. You just blew me away. The fact that you showed up to these events and you were putting yourself out there, so much to be said for that. And I'm so incredibly proud of you to start your journey into becoming a CRNA. I look forward to seeing you again at future conferences. So you guys, I shared this success story because it is full of little golden nuggets. So I really think you should stop and rewind and jot down some notes. CSB would love to share more golden nuggets with you, so be sure to sign up for our free Future CRNA newsletter. The link is in the show notes or comments below. Cheers to your future. Now back to the show.
So for these patients that are harder to sedate, during induction, we usually give them a higher dose of propofol. So always have your extra syringes of propofol ready. This is a very helpful tip if you're just starting out. This is something that I always do now because it has helped me so many times. Always just draw up an extra syringe of propofol, and you just want to have it available next to you that you can just grab it and give a little more propofol and bolus them. if they need a little more sedation. We can also turn on the anesthetic gas while we're masking them so they can inhale the anesthetic gas and go to sleep faster. You'll notice that they will relax and masking them will get easier and easier as their body gets more relaxed and they are off to sleep. You can also give your fentanyl or Dilaudid or whatever it is that you like in combination with your sedatives during induction. That can also help. You basically want to use all of the resources you have that can help you sedate your patients faster. With that being said, we do have to be more mindful of how these medications affect our patients. This warrants careful assessment of their vital signs, their respirations, and their pupils. I think when you're starting out and you're very new to clinicals, you're very hyper-focused on your task at hand, that you don't always notice what's going on with your vital signs. Your blood pressure and heart rate may be dropping really fast, so you have to be cognizant of all those things while you're giving these medications. And always have your emergency equipment ready just in case, any emergency drugs. If that makes you feel a lot better by having any, if it makes you feel better to have your Stickaneo or ephedrine nearby just to help you out during induction. And have that emergency equipment ready just in case you run into trouble with the airway and anything else that can happen. And if you have a known difficult airway, always be prepared and have plans in place just so you're ready and you don't lose any time trying to get an airway on that patient. For post-op management, we're going to continue that multimodal approach, ensure that their pain levels are controlled, and that they are monitored closely for sedation, respiratory depression, and any behavioral changes. Our job doesn't stop after we leave the OR. We still have to take care of our patients and manage them post-op. A lot of things can happen post-operatively: codes, airway issues, surgical site issues, delirium, psychotic episodes, nausea and vomiting, eye injuries, the list goes on. And since I've just had my pediatric rotation, I figured I can add this in since it takes a lot of anesthetic for these little guys to go down. And if you haven't done your pediatric anesthesia rotation yet, or you don't know anything about pediatrics, sometimes they require a lot of anesthetics to get to sleep. The dosage of propofol is actually higher in pediatrics compared to adults. The dose for propofol in kids is 2.5 to 3.5 milligrams per kilograms compared to adults, which is 1 to 2 milligrams per kilograms. These kids can be extremely anxious because they're separated from their parents, they're in an unfamiliar environment, and their emotions are at an all-time high. For kids who do not have an IV, if they're less than 7 or 8 years old, we do a mask induction. And if they're calm and they're able to breathe through the mask without any issues, we start them off with nitrous oxide. And if they are crying, thrashing around, and uncontrollable, we turn up our anesthetic gas all the way up to its maximum level and place that mask over their face and have them breathe that gas in until they're asleep. Once they're asleep, we place an IV and we're able to push any other medications that we want to through that IV. When you have your anesthetic gas at a very high level, make sure that you are very mindful of their heart rate, because with pediatrics, their heart rate goes down very quickly. So when you hear them breathing down, turn down your gas right away. That is always the first thing you do when you have your gas all the way up during induction and you see them braiding down. Emergence delirium is also a very big thing in this population. It's very common in toddlers. I've seen it many times during my pediatric rotation. A lot of providers like giving Precedex before the case ends, and that gives a smoother wake up for these kids. I hope you guys enjoyed this episode of the CRNA School Prep Academy podcast. It's been a real pleasure talking to you guys about patients that are harder to sedate and what we see in clinical practice. You can reach me on Instagram and YouTube at SRNA Paul, and I will see you guys again next time. Thank you. Bye.
Hey, future CRNA, as always, I appreciate you and your loyalty. Thank you so very much for tuning in this week. I'd love to hear from you, so screenshot this episode and share it to your IG stories with your biggest takeaway. Don't forget to tag me at CRNA School Prep Academy so I can personally thank you. Be sure to head over to CRNASchoolPrepAcademy.com to check out our blog and gather free resources to help you along your CRNA journey. Stay strong, and I'll see you next week.